Chapter 2, Theory, Research, and Evidence-Based Practice. Okay. Will you as nurses perform using evidence-based practice?
Yes.
Yes.
Yes. We're not going to make up a recipe that we heard years ago, right? Okay. So the social policy statement addresses the promotion of health and wellness, not only for our patient's family, but of ourselves, okay? We promote safe and quality care. When you go into your patient's room, I expect it to be clean, okay? Clean up they have all their crap, they're like brought their camping gear, like, put it away. Their trailer, whatever. You know, you have to have room to maneuver in the room, okay, and they need to be safe. We care, we do self-care, we coordinate care, everything's about care, okay? We offer physical and emotional support, spiritual comfort. What does emotional support look like when you're caring for a patient? What's an example of emotional support?
Just like listening to their concerns.
Listen to your patient. If you're doing an assessment on your patient, let's say I ask someone, how is your chest pain? Is it burning, radiating? Oh, it's burning. Don't put words in their mouth, okay? Ask the question. Sometimes I get excited and I have to tell myself to swallow because that gives them time to respond, okay? I am a bad person when it comes to putting words in people. I do that. Emotions related to experience of birth, growth and development, health, illness, disease, and death. Okay, we will experience a variety of emotions. Happy, sad, mad, glad, all that. Okay. The second policy addresses the linguistic and cultural sensitivity. We do have a cultural assignment that will be due sometime in this 8 weeks. I have to decide where you guys are gonna pick a culture and look at medical interventions. Making sure you are culturally sensitive when you are providing care for that patient. Okay? Sometimes I had a patient that came into the emergency room, and every time I would ask a question, her brother would answer. Okay? And that was a cultural thing. Okay? The man of the family is the one that answers you. The man of the family is going to consent to things, not the patient. Okay? And I needed to be okay with that. So realizing that there are cultures that you're going to come across. Okay? Decision making and the ability to make choices. Are you going to make a wrong decision? Yes. The best thing that you guys can do, we had a policy at Davis, and I'm going to swear, fuck up and fess up. Okay? You make a mistake and you own it. Okay? I messed up. Those are the ones that you're going to learn from. Okay? My first medication error, I was a nurse for 1 day. 1 day, and I made my first medication error. I went to my colleagues who were like, I mean, and it wasn't like really no big deal, but like, they're just like, why are you telling me that? I don't care. But I was like, I made a mistake. I wrote myself up. Okay? So being able to make a bad decision and learn from it. Okay? Yes?
How does that work legally or logistically for somebody else to consent for the patient? Like if it's, I guess, yeah.
Like if it's a
at
cultural?
What level of direct family is needed, or just how does that work logistically?
Each hospital has their own policies governing it. At the hospital that I was at in Sacramento, we had a large population where the male of the family would consent to care. And so the female would be like, no, I don't want that. And the relative was like, yes, do it. And we, you know, if they have ethics departments, and I guess if I ever was in a situation where I was not comfortable, that I would have ethics involved. And just have them bring in the team and with their fancy lawyers, and they can kind of delve into what's happening. Yeah, it gets tricky, really tricky.
Couldn't they get around, like if the men were the DPOA of the patient, then it's immediately
Yeah.
like fine, even if they're like totally with it.
Yep. Yes.
How much, if at all, would that change if the patient's condition was critical?
If they're critical, you have a duty to act as a nurse. think of this, in a court of law, if you saw your patient having an emergency and you did nothing because the family said not to, and you have all this training and could help them, you have a duty to act. Okay, and that's in a standard practice.
Kind of a specific question combining those. If, like, we had someone who had a head bleed and then the family wanted them to go home and do their own practice, but it became like quite an issue because that's not at all what's medically, like, where do you lie on that? Like, do you try to force them to stay?
That gets tricky. I would have an ethics committee involved right away. We took care of a patient that we flew back to India with a head injury, and they wanted to care for that patient utilizing their own practices. I don't know anything about the healthcare system in India. I don't know. And so I know what we can do here in the States and, what, standard of practice for this patient. But getting the ethics committee involved is super, like, that would be my first bet. Going to your charge nurse, I'm in a situation where I'm uncomfortable, and then notify the ethics committee and get them involved early so that they could kind of get some research and background on what's happening. I mean, you can't tell them no,
How about blood transfusion? Like somebody just would, like, they are against it, they don't allow it, and
Yep.
if the patient doesn't get it, might die, like,
They die.
what do you do?
I've had a number of patients that have refused blood after a massive accident or an emergency aneurysm surgery or a heart surgery,
I mean,
and they die. There's certain substitutes that you can give, iron dextran, certain vitamins and minerals that you can give. Certainly I offer those, and I talk to the patient about what else I can do to increase their red blood cells. Sometimes I've had patients that the family wasn't ready to let the patient go, but he couldn't have blood, but blood was coming out of his chest tube. And I went as far as to say, can we give him that back? Like, can I give him that blood back in the tube? You can. But it just depends on what the family wants, and it's their religious belief, and you have to advocate for that. If that's what they want, that's what they want. And it's very difficult to stand there and sit there with a patient who you know is gonna die because of that. Okay? But you offer alternatives, vitamins, minerals, is asking the doctor or provider, is there anything else we can give or offer them? Okay? Any other questions? Let's go into another question. Tell whether the following statement is true or false. Traditional and authoritative knowledge are practical to implement, but are often based on subjective data, limiting their usefulness in a wide variety of settings. What is subjective data?
Subjective is what they feel and you can't quantify it.
So objective is something you see, right? Oh, glasses on? Subjective is what they tell you. I hurt, I'm in pain, I'm doing this. I love to do quotes when I'm charting, and like, if there's a swear word, I put it in quotes. But like, 'cause you can't get in trouble, right? 'Cause it's what they said. So, yeah, just put it in quotes. Okay, so that answer is true, okay? So traditional and authoritative knowledge are practical to implement, but are often based on subjective data, limiting their usefulness in a wide variety of settings. If your patient says they're having pain, and they're talking and laughing on their cell phone, are they having pain?
A little
Yes.
bit.
Subjective. Pain is what the patient says it is. Okay? They come in on the ambulance after a car crash holding their phone like this because they're on live. Oh God, I'm in 10 on 10 pain. And I'm sitting there going, okay. But no, they're having pain. I have to treat their pain. So subjective data is what the patient tells you. Objective is what you see. Okay? So some other influences on nursing, we all talked about Florence Nightingale, okay? There's also societal influences. Okay, do you think our government influences nurses? Yes. They also influence healthcare providers, you know, approve or deny your prescriptions. Okay. So the framework of nursing theory, okay, you guys will see this as a question. Okay. A theory is a group of concepts that describe a pattern of reality that can be tested, changed, or used to guide research. That's why we do theory. To test it, to change it, to guide research. Okay? Some concepts could be like abstract impressions, organized into symbols of reality that describe objects, properties, and events and relationships among them. Okay? The big thing about theory that I want you guys to know, it can be tested, changed, and it guides your research. That's the only 3 things on this slide I want you to know about. Okay? You guys don't mind if I skip the stuff you don't need to know, do you? Okay. These 2 questions you'll see as well. The difference between deductive and inductive reasoning. I want you to know this. Okay? Deductive reasoning examines general ideas and considers specific actions or ideas. Inductive builds. Okay? So it's like inducing something. It's building up from specific ideas or actions about general ideas. Okay? Another question. Tell whether the following statement is true or false. A nurse who tests a nursing theory by examining a theory itself and then considering the specific actions or ideas is deductive reasoning. True or false? True. Good. So a nurse who tests a nursing theory by examining the theory itself and then considering the specific action or ideas is using deductive reasoning. I guarantee you'll see this on a test. Just star it, highlight it, whatever. I'll not hide anything from you guys, okay? So there's an interdisciplinary base for nursing theories. There's 3 different theories. Okay? There's a general system theory, and an adaptation theory, and a developmental theory. Okay? The general system theory is a universal application. Okay? It breaks whole things into parts so you can see how something works, how things are put together. Okay? The adaptation theory is an adjustment of living matter to other things in the environment. Okay, so you're looking at someone's environment and how they're kind of maneuvering for things. Do they have grab bars to get upstairs? Okay. Do they have a commode to go to the bathroom in? Like, what does their environment look like that's helping them adjust to something? Okay. The developmental theory, we've heard this since we were little, right? Is predictable growth and development from birth to death. Okay, so their level of development, where they're at on the span. The goal of these frameworks, this is a test question, is to provide holistic patient care. What is holistic patient care? The entire patient. Okay. Do I care that they just robbed a bank? No. Okay. You provide care to the whole patient, regardless what's going on. Okay. It's individualized. Meet the patient where they're at. Okay. If you're working in an emergency room, they're probably going to scream and yell at you because they've been waiting in the waiting room for 8 hours. Meet them where they're at. I understand you're frustrated. I hear what you're saying. Okay. Remember, we're going to be good listeners to our patients. Okay. We're going to promote health. By promoting health is when we prevent or treat illness or injury. Okay? You have a little kid that crashes his bike and wasn't wearing a helmet. What do you think the nurse's job in promoting health is going to be?
Wear a helmet.
Do you own a helmet? Maybe they don't have money to buy a helmet. You know, nursing helmet. Okay, a nursing helmet. I need one of those sometimes, but, you know, so we're gonna promote like health, okay? Some common concepts in nursing theory: the person is the patient, the environment, health, and nursing. We'll skip that. Yes.
How do you feel about the change in vocabulary for patient and client?
That was, that's kind of like taking the Marriott model and saying the hospital's like, you know, kind of adapting all their stuff to the Marriott. You know, we make the reception look all nice when the room doesn't look so great. I prefer it to be patient myself. And that's just my old, like, I really don't care what they want to be called, honestly. I just take care of them. What about you? What do you think?
I feel like it's kind of devoid of the connection aspect of it.
Yeah.
It's kind of, yeah,
They're not paying me for care directly.
I don't know how to use clients when it's like they're paying me for
yeah.
It's weird.
service.
Yeah, it's
Under-
weird.
Sounds like a business. Yeah.
That is how healthcare is viewed here. Unfortunately, in America, is they view it as a business. And so a lot of institutions like to, you know, change it to client. They're paying for a service. Just feels weird to me. This is a good picture that I want you guys to look at. It's a woman in a wheelchair with her nurse that's sitting beside her. Let's pretend my patient is in bed. Okay, this is my patient. He's laying in bed, hospital bed. I come into the patient room and I'm standing at the foot of the bed. What do you think that looks like to the patient? Intimidating? Power play? Yeah. It's intimidating. Come over to the side of the bed and talk to the patient. Okay? Pull up a chair. Sit down and talk to them. Okay? Meet them where they're at. Don't just stand at the foot of the bed. I'm in control of you. Because that patient has given up all control by going into the hospital. All their autonomy is gone. They're going to bed when you turn the lights out. They're taking the meds when you bring them. You're telling them to turn. You're telling them to eat. You're telling them when to go to the bathroom. Okay? They've given up all sense of control when they come into the hospital. Okay? So I want to meet them where they're at and provide care. Question number 3. Which of the following is a central theme in the theoretical framework of nursing? Is it the person receiving the care? The healthcare environment? I missed the T there. The nursing care plan? Or the person providing the care?
The person receiving the care.
It's the person receiving the care. That's the person that matters. Okay? I don't want to go into this. What do you think the goals of nursing research are?
Evidence-based practice.
Evidence-based practice which betters patient care, improves patient outcomes. That's the meat and potatoes of nursing research. Educate, policy development, ethics, that all comes in there too.
Okay.
Some methods of nursing research. Okay, we don't have a nursing research class here, but quantitative, does anyone know what quantitative research is?
Anything that has to do with data and numbers.
You can measure it, it's measurable, right? What about qualitative? Describe. Like if I interview someone and I ask them questions, is that qualitative? Okay. I'm not collecting numbers, I'm just collecting their thoughts. Right? Those are the big things I want you to know about that. No. All right. True or false? The basis of phenomenology is the discovery of how people describe their own reality and how their beliefs are related to their actions in a social scene. What do we think? True or false? False. The basis of grounding theory is the discovery of how people describe their own reality. and how their beliefs are related to the actions in the social scene. You'll see this question again. Highlight it for the STAR narrative.
What is phenomenology?
Good. Anybody else? What do you think it is?
I have no idea.
Okay. So it's related to cultural phenomenology, upbringing, beliefs.
The word is a little misnomer.
It gets a little tricky because it does go into beliefs here in that answer. Okay. All right. Evidence-based practice is a problem-solving approach to making clinical decisions using best practice. The care that I deliver is based on evidence-based practice. We're guinea pigs when you go to the hospital, right? So I can say that this worked for this population but didn't work for this population. They're constantly being studied, okay? It blends both science and the art of nursing so that patient outcomes are achieved. That's all I care about with evidence-based practice. How can I best care for this patient that's going to help them? What's been done in the past? Okay? Unfortunately, during COVID, we had never seen something like that before. Okay? I was going to Travis Air Force Base to learn how to put 2 and 3 patients on a single ventilator. Better hope no one coughs. Okay? We ran out of sedation. I was giving pain meds knowing my patient wasn't sedated. We didn't have anything. It was pure survival. We came up with protocols about which patients we were going to treat based on necessity. Does that sound like good health care? No. If you were over the age of 35, if you had a BMI over 30, if you had any pre-existing medical conditions, might limit the care that you received because of necessity. We ran out of resources. We didn't have enough ventilators. When we walked into work every day, there was a freezer truck out front. What do you think was in that truck?
Money.
Okay. Granted, I was at a very large hospital. We got transfers from everywhere. So we had the ability to do things like ECMO, where we could bypass the heart and just oxygenate the body to let the lungs heal. Okay? We had patients that were face down 50 in a row that we had a lift team that specifically went around the hospital and flipped, 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 flipped every hour. We were learning at that time how to care for patients. So we didn't have any evidence to base anything off of. It was trial and error. We learned that we could better oxygenate the patient by them being face down. So now it's standard protocol because that's what worked. Okay, so there might be some pandemics that you guys are going to be exposed to as nurses. You know, when Ebola first came out, we were so worried about that. We ran out of PPE and we were using garbage bags and duct tape. There was one patient in the United States with Ebola. And we were prepared for it, but we never saw him. Okay. We'll go into this in lab tomorrow when we talk about TB and measles. We've heard enough about COVID, okay, but measles is here, TB's here. There's evidence-based practice for that. Okay, now there's evidence-based practice for treating COVID patients. And that was purely based on experiment when we were working in the hospitals. Okay, yes?
Since COVID, have there been any like framework policy changes? Like the system adapted for round 2 of the next big thing?
There's preliminary plans. You know, I think they look at the sporting centers as creating like a MASH type hospital, where our next effort was, once our hospital was full and it spilled out to the parking lot and we had tents of patients, Then we take them over to the Kings Stadium, basketball stadium, where they had student nurses working it from Sac City College, Chamberlain University. That was their clinical time. They came and they were caring for patients. They had other nurses there kind of directing them, but desperate times called for desperate measures. There was not enough nurses and not enough providers. They were expediting licensures, letting go of some of the regulations. Okay, not all nurses students got clinical time. Hospitals, ours was one of them where we weren't accepting nursing students. We had to decrease our liability while not being able to provide adequate care for our patients. We didn't have anybody. Okay. I do have some articles that I've posted on your assignments. There's no grade for those articles. I don't want to say toilet reading, but they're interesting if you'd like to read them and gain more insight into what's happening. PICOT, asking clinical questions. This is a test question. This is something that will always be a test question. Okay? P stands for patient, population, or problem of interest. When we're writing questions on a care plan, when we're asking questions to our patient, this is the kind of the format we need to have in our head. PCOT. Okay? Your intervention of interest. Okay? Hi, Miss Jones, I'm here to take your blood pressure. I've kind of addressed both things, right? Patient and my intervention of interest. Okay? Comparison of interest, outcome of interest, and time. Those are all things we have to think about. And those are all when you're writing your questions on your care plan, which we will get into later. So some steps to initiate or evaluate evidence-based practice. It starts with a question. How do we treat this condition? How do we combat this pandemic? Okay? We search and collect evidence. When the COVID vaccine came out, I remember not knowing anything about it, even though that research has been around since the 1980s. I was asking infectious disease doctors. I was searching. I was trying to collect evidence because I wanted to know, is it going to harm me or help me? I didn't know. You know, I know I didn't want to die. What should I do? Okay? You critically appraise the evidence. When you're reading research articles, you want to know if it's from 17 Magazine, Cosmo, or a peer-reviewed article. Does anyone know what a peer-reviewed article is? Yes.
So research paper gets submitted, gets examined by a panel of colleagues, professionally qualified colleagues in the same field.
So experts in the same field. It's been evaluated. Okay? After you've critically appraised the evidence, so you're looking at the validity of it, does it make sense? Is it reliable? Is it reliable to the situation that you're in? Can you apply it to the situation that you're in? Okay? You integrate the evidence with clinical expertise. So if you're reading something and it tells you it may harm the patient, are you going to think about it a little bit? You know? Is it okay to ask questions? Is it okay to say you're scared? Scared that what this might do to the patient? Okay. You evaluate the outcomes of the practice decision. So how did they respond to that pain medicine that you gave them? So that's why we do pain rounds, right? So they're having pain, you give them a medication, you come back and say, how's your pain? Scale out of 0 to 10. 0 is none, 10 is a ton. How would you rate it? We're evaluating the outcome of the intervention that we did. Okay? And then we think about, we disseminate the outcomes. We tell the doctor if that pain medicine worked or that pain medicine didn't work. Okay? quality improvement is something that all hospitals and healthcare systems have to have. It's a federal mandate, okay? It's either a group of nurses or experts in the field that will look at evidence-based practice. They'll read your charts. Everyone knows Darlene Brady, right? She was our chair. She works here as an adjunct instructor. She worked in quality improvement at Santa Rosa Memorial when I was an ICU nurse. She read my notes. Small world, okay? But she would take the evidence-based practice, take the care that I delivered and examine it and make sure that it was good, okay? Quality improvement is not to penalize you as a nurse, okay? It's to make sure that you're delivering safe patient care, okay? All right, let's go to the next one. Everyone's doing okay? It's like dry as mud. These are the highlights from the reading, so. All right, health, wellness, health disparities. All right, your concepts of health and wellness. Health is a state of physical, mental, social well-being, absence of disease, feel healthy, okay? The health of the public is measured by mortality and mortality. What is morbidity?
How you living or frequency.
What is mortality? Death, resulting from the disease process. So, health is measured globally, so around the world, by morbidity and mortality. That will be a test question. It's okay that I tell you what test questions are.
Yeah, please.
Each person is going to define the health using their own terms. How are you feeling? I feel fine. Okay? They're not going to say I'm 46, I'm tired, I suffer from anxiety, I'm overweight, I don't work out. Okay? So they're going to define their health in their own terms. Okay? Family, culture, community, society, do those all influence the perception of health?
Mm-hmm.
Yes. That is a test question. Star that, highlight it. Sorry. Family, culture, community, society influence the perception of health. So the question might read, what influences someone's perception of health? You could say family, culture, community, society. Definition of health states. Wellness. An active state of being healthy. You're well. Okay? You're living and promoting a good physical, mental, and emotional health lifestyle. Okay? Disease is a medical term. Okay? Refers to the pathologic changes in the structure or function of the body or the mind. Okay? Illness is a response to a disease. That is a test question. Okay? So a disease is a medical term that changes the structure or function of the body or mind. Your illness is a response to that disease. Okay? With hypertension, someone having a hypertensive crisis, high blood pressure, what symptom might they have? A headache. They have an illness in response to a disease. They're nauseous. Okay? Classification of illness, my favorite. Acute versus chronic. Okay, you'll get more into this when you get into Med-Surg 3. Okay? An acute illness has a rapid onset. It's happening right now. If I've had a headache for 3 months, is that acute or chronic? Chronic. The definition of a chronic illness is 6 months or more. Okay? Chronic is a slow onset, sometimes with periods of remission or exacerbation. Okay? Versus the acute, which happens now. Appendicitis happens now. Pneumonia, diarrhea, the common cold. Took me 3 years of nursing school to spell diarrhea, but I can do it now. That's a fun one. What is an example of an acute illness? Is it diabetes?
No.
Rheumatoid arthritis?
No.
Osteoporosis?
No.
Or pneumonia?
Pneumonia.
Pneumonia, rapid onset, right? There's some stages of illness behavior that you guys will encounter. The first stage is you start to experience the symptoms, the signs and the symptoms. I have a headache, I'm staying home. I'm assuming the sick role, okay? I'm assuming a dependent role. Someone take care of me. And then stage 4 is you achieve recovery and rehabilitation. What I don't like is a dependent role, okay? Us as nurses, we like to take care of people, and we like to do everything for someone who's sick and injured. Is it okay to promote their independence?
Yes.
They're not brushing their teeth, let's say. They have a broken leg. Do you think they can brush their teeth? Yes. You want to promote their independence as much as you can. They're going to want to assume the dependent, because I'm sick and injured, take care of me, okay? You as nurses, you're advocating for them. You're advocating for their independence. You're treating them like a human being, okay? I want you to feed me grapes while I listen to music. I've had that before. That was interesting. No, not gonna happen. Okay. Question number 2. Tell whether the following statement is true or false. A person who is experiencing a productive cough, what's a productive cough?
Phlegm that's coming out.
Something's coming out, right? And a fever, takes a sick day to recuperate and decide whether to make an appointment with their doctor. This person is said to be in stage 3 of illness and behavior. False. I'm like, please be false. So a person who defines oneself as sick and self-medicates or visits a doctor is said to be in stage 2 of the illness and behavior. They are assuming a sick role. I'm sick and have to go to the doctor. Okay? Disparities in healthcare. We've already touched on this. Health equity. Okay. We want the highest level of healthcare available for everybody. Everybody deserves to be cared for, regardless of what's going on, okay? Had a gentleman who shot a police officer, killed the police officer, came in with like 12 holes in him, wearing a bulletproof vest, which I thought was odd. Was it my job to judge what was happening with that patient? No, he provided care. Health equity, okay? Your job is to take care of people. Health disparity. Your particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. What do we think is an example of environmental disadvantage?
Lack of transportation.
Okay,
People that live in areas of food desert.
Yeah.
okay. It's influenced by race, ethnicity, poverty, sex, age, mental health. Do we think mental health is a problem
Yes.
in America? Yeah. Educational level, disabilities, sexual orientation, health insurance, access to health care. Okay. Some examples of social determinants of health: conditions and environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of outcome and risks. There's a lot of different determinants of health. Okay, those are all the social factors. Okay. DIE, I don't call it DEI, diversity, inclusion, and equity. This is something that is kind of, I don't want to say it's new, but it's kind of coming to fruition a little bit more that we're seeing. Institutional or structural racism, unconscious or implicit bias. I was talking about bias earlier when you're caring for a patient. If you're not comfortable caring for the patient because of your religious beliefs, your personal beliefs, your moral beliefs, it's important to acknowledge that. Okay, I don't feel comfortable doing this because of this. And that's okay. Okay? The important thing is to recognize it and not walk in and start spewing your beliefs to the patient. Okay? Diversity, you're gonna welcome individuals of different race, religion, nationality, culture, age, sexual orientation, and identity. Care for a diverse population. Okay? Inclusion, your patient is coming to you for help. Make them feel like they belong. They have a sense of purpose. Okay? Equity, this isn't the 5-year-old telling me it's not fair that Charlie got the candy bar and they didn't. Okay? This is ensuring that everybody has access to the conditions that they need to thrive. Your patient needs water at the bedside. Your patient needs a warm blanket. Your patient needs money to pay for that pain medicine. Okay? Making sure that you're delivering equitable care to that patient. What you can do as the bedside nurse is get social work involved right away. Okay, have the social worker kind of get them whatever they need. Spiritual care. Do they want to talk to somebody? Get that lined up. Who do we think are vulnerable populations that you guys will care for?
Experiencing housing insecurity.
Housing insecurity?
Elderly.
Elderly. Why is an elderly person vulnerable?
They're dependent on the care, possibly.
They might be dependent on their care. Children. Okay. What are some other vulnerable populations? Who? Immunocompromised patients. Okay. Homeless patients. Patients having mental health emergencies. It could be anybody. Anybody that comes into your door that you're caring for is vulnerable. They're giving up their independence. They're seeking you for help. Okay? Some factors that affect health and illness. Basic human needs. What are some basic human needs? Food, shelter, water. Okay? Human dimensions, self-concept, your risk factors for illness or injury. Okay? Human dimensions. Okay, no, we don't want this. Question 3. True or false? A person who keeps in touch with neighbors in attempting to foster a community feeling is promoting one's emotional human dimension.
True.
False. A person who keeps in touch with neighbors in an attempt to foster a community feeling is promoting one's socio-cultural human dimension. They're worried about themselves. Okay. Nosy neighbor, worried about themselves. This is a good one. This picture here looks at the dimensions of a whole person. Okay? This is us in the middle, and these are our dimensions that make us whole. Okay? Intellectual, environmental, spiritual, socio-cultural, emotional, and physical. That will be a test question. What are the 6 things that make the whole person? What is an example of an emotional need, an emotional dimension? Okay, whether they feel safe or not. What about physical? Huh? Hunger. Okay. Thirst. Intellectual dimension. What's an example of an intellectual dimension? Good. What about socio-cultural? Okay. So think about when you're looking at this right here, the person, these are your 6 dimensions. Think about what makes up each. An example of this, an example of emotional, an example of physical. Okay? Risk factors for illness and injury. There's modifiable and non-modifiable things. What is a modifiable thing? Wearing your seatbelt or not, right? I can make a decision. Wearing a helmet or not. Those are things that I can change. Non-modifiable things, genetic factors. I couldn't predict the car that ran the red light that hit me. It's a non-modifiable, right? 6 major areas of risk factors. You guys will see this on the test. Age, genetic factors, physiologic factors, health habits, lifestyle, and environment. 6 major areas of risk factors. Going back to our 2030 goals or guidelines on health promotion and injury prevention, that's the whole purpose of it. The primary purpose is to prompt health and prevent development of disease process or injury. Some examples of primary prevention are what? Immunizations. That's a primary preventative thing, okay? Family planning services. That's primary prevention. Poison control information, okay? Do you think as a nurse you're gonna call poison? How many of you guys called poison control before? What did you call it for?
One time I was cleaning and my kid got into my cleaning supplies.
Okay. I called it once. My daughter took a red Sharpie and colored her lips because she wanted lipstick. Freaked out. They told me it was fine. Get some cold cream on them. But yeah, poison control is a wealth of information. That's good. Accident prevention education. Okay. What do you think is something you can do as a nurse for accident prevention education?
Cap your sharks.
Pardon?
Cap your sharks.
Cap your sharks. Okay. Do you pick up a cap and go like that?
No.
No? Do you snake it around until you find it? We'll teach you how to be safe, okay? So accident prevention education. We want to look at fall risk when you're in the hospital. How can we prevent fall risk patients in the hospital? What are some things that nurses do if a patient is a fall risk? Bed rails up? Bed alarm?
Ball mats.
Ball mats?
CNA.
Lowest position.
CNAs? Lowest position?
Locked wheels.
Locked wheels? You know the guy in the yellow gown that's walking on the street corner smoking a cigarette with his IV pole? He's a fall risk. Yellow gown, yellow socks. We do everything we can. Okay, we put the falling star in your bed. You know, a little picture that you see. So a lot of things we participate in. Some secondary things, focus on screening. Mammograms. Okay, that's a secondary prevention. Okay. Assessing children for normal growth and development. Height, weight, how many words are they saying? I took my daughter to the doctor because she wasn't speaking 21 words. That's what the book says. They gave me a sticker and said, she'll speak when she wants to. She's fine, nothing's wrong with her. Okay? So assess children for normal growth and development. Encourage regular medical, dental, and visual examinations. Do you think you're going to care for patients who haven't been to a dentist?
Mm-hmm.
Yeah. Some of the sickest patients I've ever taken care of started out with a dental abscess. Okay, freaks me out. All right, so secondary prevention. That's secondary. Tertiary prevention, third type of prevention. Okay? This starts after your illness is diagnosed and treated. Okay? The goal is to reduce disability. So when you have a patient, let's say they go to Marin Health after crashing their car and they need rehabilitation. They need to learn how to walk again. That is called tertiary care. Okay? The goal of that is to reduce the disability and help rehab the patient to their maximum level of function. Okay? So if you're working in an emergency room, you're doing primary prevention. Sometimes secondary prevention. When they go up to the ICU or the ward, that's more tertiary care, right? We're working on getting them out of bed, PT, OT, helping them regain their strength, okay? This could be as simple as teaching a patient with diabetes how to recognize the signs and symptoms, okay? If they're high, their skin will be dry. If they're low, their skin will be wet. Okay? Those are some simple things that you could tell family. Okay? All right. Here's a question. What is an example of a nursing activity that promotes secondary prevention as a level of preventative care? So secondary prevention, okay? Conducting a smoking cessation class. Performing a blood pressure screening at a local mall. Performing range of motion exercises on a bedridden patient. Or promoting safer sex practices in school settings.
B.
Secondary prevention. Your blood pressure screening at a local mall. Okay? We know there's a disease process out there, but we're just trying to monitor. Okay? Trying to prevent. Early detection of the disease. Okay? If we know they have hypertension and they're being treated for it already, so they've already done primary and secondary, they then would go into the tertiary category because we want to prevent or reduce their morbidity and mortality related to that hypertension. Okay, tell them what they can do. Health belief model, health promotion model, none of this. No, don't want that. Don't want that. I'm done with that. Okay, sorry. This will not be on there. Yes, I like this. The health illness continuum. This is everything we encounter every day. Okay? When we're in the middle, we're in normal health. When we're on the left, or on this side, we're in good health. We're on the other side, we're on the illness side. Okay? So you're either normal, sick, or not sick. Easiest way to describe that. Don't like that, don't like that. All right, I think we are good for the day. All right, we're gonna get into chapter 26 next class, which is Thursday in vital signs. Okay, so we're gonna talk about now the meat and potatoes of nursing, now that I've bored you with the history of it. Okay? Tomorrow in our skills class, it's Tuesday, okay? We'll spend a lot of times doing introductions, and there's no reading assigned for skills, no assignments assigned for skills. Just come to class ready to work. Okay, comfortable clothes are fine. You don't have to be in scrubs, but just be prepared to participate. Okay, that's how we're gonna learn how to be a nurse. Okay, everybody bring your note cards out to the sides and I'll collect them. And I am here pretty much all day. I teach a class tonight at Dominican Anatomy, but I'm here and I am always available to you. If you guys got questions, let me know. Okay? Email, phone, something. Scream in the hallway. Whatever.
Thank you.
Whatever you need.
My back.
There's a